So, good evening, everyone, and surgeons from the TSTS Society. And I'm Dr. Yin Kai Jiao from Chang'e Memorial Hospital, Taiwan. And today we will start our third TSTS robotic surgery webinar. And at the third episode of our webinar, we are very honored to invite Dr. Khan from Seoul National University Hospital to be our guest speaker. And I'm sure that everyone must be very familiar with our good friend, Professor Khan. And he is now, he is the #1 key opinion leader of thoracic surgery, especially the robotic surgery in Korea. And as we know that in Asia, the penetration rate of robotic surgery in thoracic surgery is not high because everybody thinks that we got VATS and we can do everything by VATS. And there must be little value to transition from VATS to RATS. But however, Professor Khan still do a lot of RATS, and it is now his preferred choice of surgery. So today I invite Professor Khan to tell us his story and why he transitioned from VATS to RATS and what he has learned. So please, Professor Khan, please, thank you.
Thank you, Professor Chao, very kind introduction. This is my great honor to have an opportunity to present my experience in this very important meeting. And actually, we are maintaining the regular webinar series in our society. It's like this program. So we are during the webinar, we have very free to talk and very not a very official talking. So we have a very good discussion on this issue. So because today's topic is title is the from best to less and what I have learned. So I will talk about my experience on how to move from best and rest and what I'm doing now currently on the best rest and robotic surgery. Can I share my slide? How about it? Can you see it?
Yes, we can see it clearly.
Yeah. Okay.
Good.
Let's start. Yeah. From best to less. First of all, I must introduce my career, and I became a staff faculty member in 2004. And in 2005, I did the first case of VATS lobectomy. And at the time, in our country, around 2003, 4, 5, the many big centers in our country started the VATS lobectomy. We are not so late, but also not a leader of the VATS lobectomy. And I think that this case was the first case in our hospital for the lung cancer surgery. And also at that, in 2005, I did the first case of pediatric VATS lobectomy. This is our first case in our country. And 2006, I did the first case of VATS esophagectomy. And then in the late 2000s, it was a time for me to concentrate on the VATS lobectomy and VATS esophagectomy. The VATS was my major interest. And in 2008, our hospital and the boat purchased a new robot. And so I started robotic surgery in 2008 and the first case of thymectomy and esophagectomy. This is also first case in our hospital. But actually the robot progress was quite late in our country because around 2005 and 2006 and many hospitals in Seoul and they already had a robot and they started robotic surgery already. And for the lung cancer, it was quite late and in our hospital. I did the first case of robotic lobectomy in 2012. And then for a long time, I did not do a robot surgery, but currently I'm now doing the robot surgery. And 2021, last year, I could achieve the 1,000 first-time cases. It's I think it's the first positive 1,000 case volume is the first surgeon in our country. The number is quite. I think the number is quite bigger than other hospitals. So First of all, I must introduce some of my VATS experience. As I talked previously, I did 2005 the first case of VATS lobectomy and the VATS segmentectomy at that time. And however, after 2010, I could not achieve any technical advancement. And I did a new technical advancement in 2017, starting the uniportal VATS lobectomy, but it was driven by myself, and because other hospitals, many surgeons are starting the uniportal lobectomy, I started the uniportal lobectomy. However, this is not a major interest. And accumulating the experience on the VATS surgery, I reported several papers on the international journals. And the left upper one is about the VATS, pediatric VATS lobectomy. Right upper one is the VATS lobectomy for the poor lung function patients. At the time, around early 2010, many centers were doing the VATS surgery. However, and then the benefit of VATS was not clear. So currently, many people believe that VATS can decrease complication rate and maintain the good postoperative outcome. However, in early 2010, not all the surgeons agreed with that. So I want to report is that VATS is better, especially in the patients with poor lung function. And right lower one is the effect of VATS on the psychological outcomes. I believe that VATS can make the stable psychological status after operation. So, for example, anxiety and depression, and then anxiety depression scores quite lower in the minimally invasive surgery. Left lower one is comparing the segmentectomy and lobectomy. And I started the VATS segmentectomy from 2006, and so I accumulated hundreds of VATS segmentectomy cases and reported the long-term survival difference between lobectomy and segmentectomy, and could find that the result was not different between two groups. This is quite similar to the currently published JCOG study and then published in Lancet. But my opinion, my feeling at the time, around the late 2000 and early 2010, and I did many cases of VATS surgery, and I was very interested in developing the best technique. And however, after 5 or 6 years after the operation, I could not find any progress or any advancement for the technical outcomes. This is a paper that published recently. However, the paper, the patients who were operated 10 years ago, at the time, the 30-day mortality of VATS lobectomy was 0.3%, and morbidity rate was 17%, and the hospital stay was 5 days. And all of the parameters was quite similar to current one. Currently, in the 2020, we are still showing the similar result to the outcomes of 10 years ago. So I thought at the time that there will maybe no more progress using the VATS technique. So I needed something new. And 2008, our hospital bought a new robot. It's quite late, but we finally could get a robot. The robot was the second generation Da Vinci S system. And 2008, and I had a chance to visit the Sunnyvale, the company of Intuitive Surgical, and have our team was trained for a week for the robot surgery. And after coming back from the Sunnyvale, I performed 2 cases of robotic surgery in 2008. I don't know what will happen, but I just tried. And the first case was a robot Mecon operation, and second case was robot thymectomy. Then I was, at that time, I was scheduled to go to Toronto as a visiting scholar for a year. And so I moved to Toronto, and then I learned lung transplantation for a year. So I could not do robot surgery anymore for 1.5 years. And coming back to Toronto, and I did so many works. I was doing work on the lung transplantation, doing the work on the VATS lobectomy, and doing some of robot, and also I was doing the VATS surgery in children. So I was doing so many works. So in 2020, 2012, I should decided and I should focus on something because I cannot do all of this work. So I decided to try to focus on the robotic surgery, because at the time I believe that the robot surgery will be the future of our surgical technology. So, and because to do a robotic surgery, I thought at the time the esophageal surgery and thymic surgery is better than the lung cancer surgery. So I changed my main focus from lung cancer to an esophageal cancer and thymic tumor. However, doing the esophageal surgery and lung transplantation concomitantly is very difficult because the two surgeries are very hard surgeries. So I must choose only one. So I decided to give up the lung transplantation. So I'm not doing the lung transplantation anymore. And however, for the VATS surgery in children, I'm still maintaining the VATS surgery. It's quite a unique one for me. So, and many patients, many pregnant mothers come to my clinic and get help to cure after surgery. So I cannot abandon this topic. So I decided to maintain this one. So it is a very great change to move to VATS lobectomy for the lung cancer and transplantation to the robotic esophagectomy and thymectomy surgeon. It's a quite risky decision, but I decided, so I still maintain this program. This is my surgical case volumes, and the blue bar is VATS, and the yellow orange bar is less robotic surgery. And I started the first cases robot surgery in 2008, and then still the robotic surgery is number is still increasing, but the VATS surgery is stationary or decreasing. Currently, in my practice, I'm doing the VATS surgery and robot surgery in half and half. On half of cases doing the VATS, and half of cases doing by robot.